Let's finish up chapter 15 with revascularization. We left off at what predictors are going, what kind of, what factors are predictors of the success of the revascularization. And now we're going to look at briefly just some of the pharmacology. And these medications are ones that you have seen multiple times. And if we look at these medications, beta blockers, alpha blockers, nitrates, calcium channel blockers, and this digitalis digoxin, which is a newer one, these all are impacting the workload of the heart, decreasing the workload of the heart, and also will have an impact on exercise in terms of heart rate and also blood pressure. So it's important to know that when your individual has an exercise test and is taking any of these medications, and also for exercise programming. Here's another group. We remember that we've got diuretics, ACE inhibitors, angiotensin II. Those are all important for hypertension, and we have those are not really going to have any impact on resting or exercise heart rate, so not so much of an issue for exercise programming, but there are some potential considerations. And then we have our anti-arrhythmic agents. Those are going to have often an impact on your exercise response and what you look for when a person is performing their exercise test. Statins and antilipemics, those are cholesterol drugs, and then also anticoagulants. So those are all kind of a repeat of the things that we've had already and what impact the exercise has. So we want to be, hopefully you're starting to get familiar with the drug classification and what its function is. So when do we do exercise testing after revascularization? Well, we know that it's really important for assessing potential changes in the ischemic measure, whether or not someone has enough, what their function is, what their risk of morbidity and mortality would be, prognostication, and getting a baseline for exercise programming. Now, only 30% of the individuals that have like a stent have an exercise test, or excuse me, post coronary artery bypass surgery. Many of them don't, and you also want to give several weeks past the surgery to allow for the incision to heal and allow the person to be in a better psychological and physical place for assessment. And we'll see that 4 to 5 weeks is the minimum, and we're looking at the ECG, blood pressure, RPE, and symptom and the resolution of symptoms during exercise. With PTCA, there seems to be a reason, there is a value of having early post-procedural exercise testing. Are the symptoms resolved? And what is somebody's functional capacity? And how can I develop an exercise program at a level that is below the ischemic threshold? We know if somebody has the stent added that it's definitely safe and important to do. The next two slides give you an idea about what type of testing that you do. And here for the cardiorespiratory testing, the treadmill is preferred over a cycle, and there are a number of different protocols. So we have the Bruce or Elistad. Now this will say for younger or more physically fit individuals. However, Bruce is used very consistently for just about everybody. There are some protocols that are better for older symptomatic individuals and deconditioned individuals, but I will tell you that the ramping, our typical protocols have 2 to 3 minute stages. Ramping means that you're changing either you're changing the intensity of the exercise either every 30 seconds or every minute, and so it's as if you're going up a ramp, and those kinds of assessments protocols are becoming more widely used. What do you evaluate? Any measure that looks at your cardiovascular measures: heart rate, blood pressure, oxygenation, so your EKG. Also, how does a person perceive it, so their RPE, and in some cases, gas exchange, if it is possible. It's not always available. And just also notice that they were looking at rhythm disturbances. How does the heart respond with hemodynamics? What is the rate pressure product? Is there any changes that indicate myocardial ischemia on the EKG? At what point does ischemia become evident? And does a person have any chest pain, or is it just indicated on the EKG? Whether or not someone has shortness of breath, and then you're looking at some specific measures on that EKG for function. When do you do strength testing? Well, it's not going to be for a number of weeks if somebody has an open heart surgery with CABG. So that is going to be post-incision healing, and that's often 10 to 12 weeks post the procedure. And you're looking at either, most of the time, isotonic strength, 3 to 10 RM, depending upon what the individual comes in with and with their activity level, looking at peak force, strength, and also their ability to do their activities of daily living in a lot of cases. It gives us an idea about what function someone is at, and also be aware, as you'll see, special consideration, if someone has an incision with CABG or CABS, they are not going to have any strength testing for quite some time, and they definitely need to be discouraging of the Valsalva. The strength, the range of motion, that's going to be depending if somebody has had open chest procedure. That's going to influence when you do some range of motion and which range of motion assessments that you do. It is possible before somebody has procedure to kind of identify what the ischemic, to increase the ischemic threshold and kind of train or condition before you have planned cardiac surgery. And this means that you have some stress, some ischemic stress, 4 cycles of 5 minutes of cuff inflation. And think about when you have had someone assess your blood pressure and you go over 200 and you think, let it out, let it out. When are you going to let it out? 4 cycles of 5 minutes at 200 millimeters of mercury, which is basically occlusion, and then you wait 3 to 5 minutes between. Do that 4 times. So we're looking at 20 minutes of having a strap around your arm. This is what it looks like. Inflation of blood. Here's another way. Blood pressure 20 millimeters of mercury above the systolic pressure. Look at how this person has their thumb on the bell. Wrong, 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 wrong. But here you are, somebody over 65 without diabetes, stable angina, or peripheral artery disease, not taking any kind of drugs that are changing contractility, and propofol, which is pain meds. So this is 4 cycles of limb ischemia and reperfusion. Supposedly will improve the smaller vessels. When the role of cardiac rehab comes into play, or when the cardiac event, which is indicated in this pink box, the primary prevention is don't have the event. Reduce the risk, don't have the disease. After someone has a disease, it's called secondary prevention, to keep the disease from progressing. Secondary prevention includes cardiac rehabilitation in the hospital, outpatient cardiac rehab, which is phase 2, and finally phase 3, which is maintenance. And you'll see the components that are in each phase, which I'd like you to review. Cardiac rehab is really important because it does improve an individual's ability to live life, have better heart strength, aerobic strength, and physical strength. They have greater tolerance for exercise, better reserve when a greater heart rate is needed, and also better blood tone, better blood pressure. I do not know why this stopped. So cardiac rehab is important to participate in because individuals are really less likely to have hospitalization. They're less likely to be a reoffender of needing rehab again, and more likely to go back to a regular full life. We do know that revascularization patients have not had the talk with Jesus that the post-MI folks have, or the talk with the end of life, the fear of death that someone who's suffered a heart attack. So they might be less motivated. That's important to recognize. We also know that anybody that's had any kind of cardiovascular event is more likely to have depression. Also really important to know when you're working with individuals with cardiac rehab or post cardiac event that they are at risk for depression, and paying attention to their personal needs is important. And it's important to have support for participation. There are primary concerns for each type of treatment. If somebody has open heart surgery, there will definitely be some concerns in terms of the healing of the sternum, but if someone does the more non-invasive or less invasive, they're not going to have their sternum opened up. Some changes in the blood volume and blood quality, less hemoglobin, so they could be fatigued. But starting outpatient programs quickly is really advised. With PTCA, we also need to be concerned about restenosis. It's always important to be cautious and pay attention to signs, symptoms, and the cardiovascular response, no matter what treatment a person has had. When we look at a person being able to exercise at home, elastic bands or something with very low intensity increments will be really important. So starting if you only have a 5-pound weight and the next one is 10, that actually is a pretty big jump, especially for upper body exercise. Recognize the pharmacological impact of the medication the person has had on their exercise response. When individuals have ischemic heart disease, they are at risk for developing heart failure, or cardiac congestive heart failure, or chronic heart failure. And having following their changes in body weight, because with heart failure initially individuals can have a very dramatic change in body weight. That might be something, depending on where they are, would be important to be aware of. And always assessing blood pressure and heart rate response is important. And recognize that some people will feel great and others will feel very low. When someone is in the hospital recovering from a procedure, their rehab in the hospital is phase 1. And that is just getting a person moving primarily and doing some assessing on what their capacity is. Walking down the hallway, learning to pay attention to overcoming fear is a lot of it. So phase 2 should be started very quickly because phase 1 is relatively short. So we have the exercise programming review identified in this table, and with cardiorespiratory, this is going to be your primary focus with very large muscle rhythmic type activities, walking, cycling, or combined arm and leg type exercises. Things that might not be appropriate initially, depending upon the functional capacity, would be an elliptical or a stair stepper. It might be just too much. If a person has had bypass surgery, they're not going to be able to get into the pool until their incision has recovered. The exercise intensity often is determined by whether or not a person is experiencing symptoms. That symptom is going to be angina, and where somebody has that angina is known as your ischemic threshold. So you stay below that ischemic threshold and gradually increase. That will improve as a person becomes more fit. We'll see that the progression is identified in the column about the first couple of weeks progress to 5 to 10 minutes of very light intensity multiple times a day. So initially it's more of a physical movement, and as a person begins to gain that healing of their sternum, less of a chance of having any kind of negative impact, then you can start adding intensity. Resistance exercise, I know this is real small, so you'll have to look at this, but we're identifying more reps, lower weight initially, using something with elastic bands or stations is really great. And when somebody has surgery, it's going to be very limited in terms of what type of upper body exercises they can do until they are healed. Range of motion, static stretching is real important. Major muscle groups and the hamstrings and back are going to be important because people will often spend more time sitting as they're recovering. When we look at the type of activities at cardiac rehab, you'll see that machines will be used pretty frequently. dumbbells, and also here there's a lat machine. And what's really great is this individual has good shoes on and looks like he's dressed for activity. And we're always going to be evaluating for form and function. And here's some stretching. So you have your last two slides are primarily your review about each different area, why the exercise training is going to be important. It's going to help with all of our components of fitness, our cardiorespiratory, skeletal muscle strength, endurance, flexibility, and also body composition. We know that more individuals are having these procedures and that exercise programming, risk modification is critical for prevention of recurrent events.